right, thank you for staying with Daybreak. Let's start that conversation first on state of healthcare, but for now, let's take a look at the dailies first and then get into that conversation at the top of the hour. Dr. Davji Atela is joining us online. He's the CEO and Secretary General, KMPDU. He's joining us from Mombasa. And Dr. James Nyikal, member of Health Committee and also member of Parliament for SEME, is with us here in studio. And Dr. Nyikal, I'll start with you on this one. We've seen the recent gloves off chit-chat between the president and the deputy president when it comes to politics. What do you make of that entire fiasco where the leaders are now just going bare knuckle?
Well, I think that is the expected end of what started a long time ago between the president and his deputy. Yeah. Way back, it was clear that things were not running well. Definitely after the handshake, it became clear, I think the president held back probably as expected of an elder and head of government and the state. Really is the head of the country, so I think he held back a bit. And his deputy went bare knuckle a long time ago. Yeah. Now, when it's come to this end, it's coming to his term, it is unfair to expect the president not to be concerned how things will be after he has left. So he will definitely make political decisions, which he will state. And I think the deputy president has also not been kind on his boss. Even if he's leaving, he's been very hard on him. And it's natural that the president can now come out hard and say it as it is or as he sees it. Yeah. I'm not surprised at all that is coming.
Two things the deputy president said. One, he said that Jubilee, if it wasn't for him, Jubilee itself would not have been there. Do you agree?
Well, I don't agree that because even when they came together, the president actually had a higher chance in the original party. Yeah. The deputy president came with a smaller party. I think it was URP, and they had one of the president. But I think that even at that time, the president was a bigger partner than the deputy. So I don't think he's saying it would not have been there. But let's make it simply. Suppose he made the proposal that they form Jubilee and the president refused. Would Jubilee have existed? So that's a relatively presumptuous and a little bit arrogant statement to make. Yeah, I wouldn't have said it. Okay. I would have just said I made a serious contribution into Jubilee. Yeah. But now it has come to this, we are parting. I think sometimes you have to part with honor. Okay. And not with vitriol. Okay. Yes. And he also said that the president is looking for a puppet, and he was referring to Raila Odinga. So he was saying that the president, the current president, wants a president he can control because he never supported him before. Well, I think that the country can tell for itself. We really can't say that if you are looking for a puppet, you are going to pick Raila Amolo Odinga. For years, from the time he started politics when we were still little kids, some words were barely born, he has always stood on his own. And he has actually gone through a lot because he didn't want people to control him. He had a clear idea what he wanted in politics. Now he has a very clear idea what he wants for this country. And he has taken decisions that has actually cost him what would have been an easier political future. When he decided to take on the Mao issue, he said, I can lose my elections on this. Well, whether that's why he lost elections, another idea, but it was clear he can do that. When you post the first constitution, I think 2005, it was clear that if he went against his boss that time, President Kibaki, and lost, he would lose his job. And he still went ahead and headed the opposition to the constitution at that time, the first constitution. So if he was somebody that was easy to control, it would have been clear at that time. So what Ruto is saying, maybe very young people, school children, may actually believe that But most Kenyans, I think, will laugh it off. I will definitely laugh it off.
Okay. Dr. Davji, what do you make of this public spat between the two principals in the country, the head of state and his deputy? Davji, unmute your microphone, please.
Okay, I'm just saying, you see, politics is a game of interests. So when the interest of the two political leaders is now divergent, then now they have to take different directions because they don't see the future together anymore. And that's why it's automatically they'll come back and address different and completely opposite dressings, which now will have different agendas. That's why I think now we can see the president having a different agendas and driving different issues regarding even the period that have been in office, and the same to the deputy president. Ideally, I believe the interests are now not aligned, and that's why we have the talks that are going on now.
So for you, do you think it's a two-horse race? Because that's another conversation that has come up several times. Are there many other options that people should look at?
I think so far I can think it's a two-horse race because of the way or the nature in which the two leaders have packed themselves and the response that is also coming out from the public. It's ideally either we're going to have the president as Raila Odinga or we're going to have president as Ruto, depending on how much they're going to invest in the politics between now and September.
Yeah.
And ideally, you'll realize that, for example, in the health sector, we had what you call a People's Health Manifesto, the half-year nation, which categorically looks at between the two leaders so far, based on the support that they have in the country, which direction are like the health leaders are going to take for the same. Yeah. So as of now, I would really say that it's a two-horse race for this election.
Dr. Nyikal, is that a fair assessment? That's a two-horse race?
As things stand now, it's definitely a two-horse race as it is. Because if you watch at the way things are moving, obviously it will be the collisions. There is Azmi on one side and there's Uda on one side. And now Uda has now come in with Mudavadi, and has got itself a new name.
Kenya Kwanza.
Kenya Kwanza.
Yes.
So that now seems to be the main. And there is
One Kenya Alliance.
One Kenya Alliance.
Yeah.
But obviously when you look at it, One Kenya Alliance is relatively smaller in comparison to the two. Yeah. And in my mind, the term two-horse race does not mean there are no other horses. Yeah. In my view, it means there may be other horses, but the ones that actually leading the pack and that people are looking at are two. In that context, for me, it is basically a two-horse race at this time, and likely to be at the other time. Because again, when you look at Koa Kenya, if you look at One Kenya, well, let's look at Koa Kenya. You still get the impression that they would shift and join one of the two. So that again makes it two-horse race.
Okay. The EACC is looking for more powers to summon or even to stop people from running for elections. Is that where the solution lies? Because you can see a few cases also coming up. On the front page of the Daily Nation, they're saying Hague clouds hang over DP. The ICC wants to interview witnesses who testified against Ruto in his post-election violence case.
Well, it need, actually, if you're going to run a fair and a free election, it should actually be free of violence. It should be free of fear. Yeah. It should be free of intimidation.
Yeah.
So the EEC really is the best placed institution now to sort out that. But as we know now, it doesn't have powers that can actually make it act fast. Let's even leave alone even the issue of violence. Look at even voter bribery. That is something that you really need to get it out of the way in the country as it is now. But who can take care of it? But even if they were to see it happening, what powers would they have to actually take somebody, prosecute them. Those who are giving and those who are taking.
Yeah.
So I think they do need more power so that in terms of election issues, if there is something going on that is untoward, then they can move in and take action and make it definitive, and so that people know that if you do this, this is going to happen to you.
Yeah.
And with politicians, the most important thing you can do is say you are barred from running, or because of this you will not run again, or you will be charged and taken to court. If you don't have the powers to do any of those things, then obviously you can't do much. And I agree with them that they should look for more power, and I think Parliament should come on. I think they were with the Justice Legal Affairs Department, and I think we should look at ways of making them stronger than they are now.
Okay. Davji, as we wind up on this conversation on politics and then get into the UHC coverage there, do you have confidence in the IBC to conduct a credible poll?
Yeah, I think as it is now, it's I think I have a confidence in them. And what now we need just to be done is to the review of the IBC team. That both the parties, the different candidates must have a say in the IBC that conduct the election. They should both be, they should have talks. Not the last time that we have election in 2017, there was no involvement of the parties up to the point of election. But I think if there's frequent updates with the IBC, then there will be possibility of having a fair election.
Okay.
I wanted to do something on that thing of ESCC.
Yes.
Particularly on the part of accountability of leaders in the counties, the county government leaders. I think if the power is really strengthened, it would be a good thing, because we have many leaders in the counties that have gone strongly against Chapter 6 of the Constitution in a way, in either an action that they took or in action that they did not do, to the point that if the same will come to contest to be leaders, then I think the residents or to the people they represented in the previous, in the ending term, will actually be an unfair thing to them. So if ECC is able to bring people down and make them accountable for every actions, it will be a great thing.
Okay. Dr. Nikal, IBC, are you confident
that
they will conduct a credible poll?
As of now, they are trying, and I often don't want to cut people off and say, I don't think that will do it. What I'll say is that they still have a lot to do. In terms of the preparations. If they prepare themselves, they get the timelines right as they put it out, abide by them, and strengthen the structures that they have for handling any fallouts. And like now, I think we've just started, we are on the issue of registration of voters. They will now have to compile that register properly, and then the figures are clear. You go to the voting station on the day and things run out, then they can do it. But unless they do that, and we don't know how much they are prepared now, even with the electoral materials, they can, but they still have a lot to do.
Okay. Yeah. I want us to shift gears and now talk about the state of healthcare. Dr. Nikal, I'll start with you on this one. It's been launched by the president to all the 47 counties now. What does it actually take to achieve universal health coverage?
Yeah, before that, let me just correct something that I said a little back. When I was, we were talking about one or two horse race.
Yes.
I referred to One Kenya Alliance as Okoa. Well, maybe I think I should correct that. I meant One Kenya Alliance.
Yes.
Yeah, whoever picked it should correct that. Okay. Universal health cover for Kenya is something that is a must. And I must say that the efforts that are going on are commendable. What are the main components of a cover? The main ones are actually financing. How is healthcare financed? Well, if you get your finances right, then the next one is actually health human resource. The people work on that. Then if you get that one, then you have to get into infrastructure and the supplies. Now, if you get all that, it will work. The intentions as they are now are good. We can see the efforts to strengthen NHIF and strengthen it, restructure it, so that it is the biggest source of money that we have now that can actually carry the universal health coverage program. So that, I think that is going on. We are also seeing an effort in improving the health human resource. There are legislation that are coming, but I think that one is still a bit of challenge. The other one is improving the infrastructure and the management of all this. Definitely there are challenges, but the ingredients are there. If we work hard enough as a country, I think it is something we can achieve. But as it is now, the efforts are good, they're in the right direction, but we haven't got there yet.
Okay. Davji, what would it take to achieve universal health coverage?
You know, universal health coverage principle is basically based on this health as a human right in the country. That means there is need to have an accessibility, affordability of health to all. But when you look at, for us to achieve this universal health coverage, then we must have actually good governance. And ideally, it's a very good principle that it's a presidential initiative. But then the implementers to ensure and to realize that we have the universal health coverage is back down into the county governments, which I will bet there's no good governance. So if we don't streamline the governance of healthcare to the point that the decision made at, let's say, the national level will be able to go down to lower facilities, then realizing universal health coverage will be a dream. So that aspect of governance has been a problem. And when you look at those pilot counties, you realize the same thing. That as much as there can be it's a very good vision with good policies and good plans, if it goes down to the governance who will not put finances that are needed to that healthcare, then you won't realize it. So that should be the debate that I think will debunkle and bring out the real aspect, that we need enough financing, enough human resource, enough infrastructure that do not only give us the brick and mortar, but really offer the quality services that every Kenyan will want to get.
Okay. Dr. Nyikal, give me your assessment of the pilot. We did the pilot in Isiolo, Machakos, Kisumu, and Nyeri. What went wrong and what went right?
The pilot, actually, when they started the 4 pilot areas, basically what they did was support those areas so that those who registered would get the services. So they gave the support to the facilities, they made the consumables available, and I think finances were available, and then people registered. The reports that have come out, what has been obvious is that it increased consumption, which means people needed the services that were there.
Yeah.
Concurrently, there was also registration of NHIF.
Yeah.
But what happened in places, I would say, for example, I'm sure in Kisumu, people then, when they registered for these pilots, then they didn't register for NHIF. So what has happened in some areas is that when now the pilot stopped, they found that their NHIF registration had gone down. But I think some areas actually continued at the same time. So what has come out, it has indicated there's a need for people to get this, and people need the service, and they showed that it can work. But it also showed that it is very important how people are registered into a system that will give them a universal coverage. It also showed that the funding can be targeted to health, but I think it came out a little more expensive than one would have liked, or than one would then carry into the full program of UHC. Yeah. So I think there are lessons we learned there. It also showed the importance, in fact, that is probably the most important. It also showed the importance of health human resource, because it was dragged down a bit by the issues of industrial action by the health workers during that time, which is to a large extent is the management of transition from national system run nationally as one, and the system that is now devolved. But I know that has been realized, and they are working on it through the intergovernmental relations structures. Yeah. So it showed the need is there, it showed it can be done, but it showed sometimes it's very expensive, and it showed the structures that need to be in place, particularly human resource and also supplies.
Yeah. Is the solution on NHIF? Is that where all eyes should be?
It's not, as in Kenya now,
yes.
If we want to have a universal health universal health coverage, as I said, one of the most important things, I can say the most important is financing. So there are two ways you can finance universal health coverage. Yeah. One, you can use tax money. It's tax-based. You collect enough money, you run health services, the government pays through the taxes, people walk out, and people walk in and walk out, and they don't pay anything. Yeah. They call it the Lord Beveridge system. That is what they have in UK. And I think that's what we had very early in this country, around and just before independence. Yeah. Or you can actually finance health through insurance, particularly social health insurance, where everybody, if possible, pays some insurance according to their means. Yeah. And then everybody gets health care according to their needs. So you bring in an element of solidarity. And that insurance money is normally a big pool. It is the one that most countries have used. So it is actually the one that we have chosen to use. If you have chosen to use insurance as a form of achieving universal health coverage, then the institution that we have now that has the capacity, despite what we think of its shortcomings, but as the structures that can be strengthened to achieve that is NHIF.
Okay. Davji, what do you think? What is the best way of financing healthcare? Should we go the insurance way, or should the government just take up the role of financing healthcare? Because there's also been concern from people that even though we are going the insurance way, there's no standardization of costs and payments. Davji, unmute your microphone.
My take on using the insurance model, or rather using the NHIF, is the part of the service provision. As much as we have many or majority of the Kenyans will be able to be contributing to NHIF, and then NHIF will be a pool to have the funds. What about the service provisions in the public hospitals, that basically, and in other facilities? Because basically, if you contribute, then it means you need to go to an hospital that then offers you the services as required. But you realize that it's opposite. If you go to many of the public hospitals in the counties, you will not be able to get the services as you need. And most of the time, you'll be forced to go to a private hospital to get the service. And that was basically based on one of the studies that was done last year, whereby over 80% want to get the services, but they go to the hospitals and they don't find the doctors because they've not been employed. They will go, and if they find the doctors, there'll be no drugs. So basically, when we are getting down into the insurance model, basically the NHIF, the government also need to invest more in healthcare. The annual budgets of healthcare of 6% need to increase to 15%, and to ensure that there is a robust service provision by not acting only on the infrastructure, but ensuring that there's enough human resource in every facility to offer the services when you go to the hospitals with the insurance.
Okay. Dr. Nyika, let's talk about this in three different ways. There's accessibility, there's affordability, and there's standardization. Mm-hmm. Let's start with accessibility. What is the best way to ensure that people have access to healthcare? What should we do? Should we have dispensaries in each and every sub-location? What happens?
When you talk of access, there are two issues in one. One is financial access. the health services may be there, but you cannot see them. You may be living next to a private hospital,
but you can't afford it.
Yeah, you can't afford it, so you don't go there. The other one is physical access.
Yeah.
Other facilities there. Now, in terms of financial access, that is where insurance comes in, social health insurance in particular. So let's assume that we do that, then we now have finances to cover so that everybody can go in. We can go into more details about that. Physical access is also important. It's not just the physical facilities. First of all, we should make sure that across the country there are physical facilities which will be used to provide the services for which will be paid for by the insurance, so that across the country we must have the facilities. And now in this country we actually have levels of facility.
Yeah.
We have level 1, which is actually the community, probably the most important one, because that is where primary health care takes place. That is prevention of disease,
yeah,
promotion of health, and early detection of illness, and quick treatment, which is always cheap. So that is actually what will control the cost. But leaving that alone, what most people think about is level 2, where you go to small facilities that take good care of you. Level 3, where you can get some deliveries and so on, so a little more complex. To level 4, which is what used to be district hospitals, where you can get virtually almost all levels except very specialized care. This must be available across the country.
Yeah.
In physical terms. And in my view, if you're looking at a successful system, we should not just be thinking of public hospitals. There should be public facilities. There should be public facilities. There should be private facilities and faith-based facilities.
Yeah.
And if the payer is one, that should make it possible for people to access all these. Maybe in private facilities, they may have co-insurance or co-payment, yeah, because the universal cover may not, as it is, the insurance may not pay for that. But those facilities must be there. If they are physically there, and international standards is really nobody should travel more than 5, in the rural areas in particular, more than 5 kilometers, yeah, to the nearest center. If we can get that available, and it is possible in this country, yeah, in the devolved system, physical facilities are actually there. And I think we can put more. The governors can put more. Yeah. And they've actually tried to do that. Now, what then comes next? It is physically there. Mm. Are there people, health workers, who will take care of you in a proper, with the skills that are needed, yeah, with the human approach that is needed for sick people? 3, are there the supplies that they need? And if you go higher up the levels, are there the equipment that they need? Yeah. So that is really something that we must work on. And over time, we have been working on that. You hear programs that support level 2 and level 3. You hear of programs that support level 4, and you hear of programs that bring in equipment like the mess. They have their problems, yeah, but it is an effort that is there. So we must make that available. Yeah. It is achievable, yes, but we have a problem, as you said, of standardization. Yeah. Again, that is now with the national government, the Ministry of Health. Okay. There have to be standards. When we say level 3, yeah, it should not. We are not just talking about public facilities. Yes. Even in the private, there should be that equivalent. Faith-based should be equivalent. Okay. At that level 3, yeah, you should get the same services, okay, across.
We'll come to standardization in just a bit. Let's finish up with access first. Dr. Davji, what is the main issue when it comes to access in your own assessment? Because I know you've been in this industry for a while.
I think the main issue of the access so far within the hospitals will be the human resource aspect of it. I will say, as my colleague, Dr. Nicholas explained, that you realize that there is the infrastructure, that is the hospitals, the brick and mortar. The governors have actually done very well in that, in building and ensuring that there are hospitals everywhere. And we have them as level 1, 2, 3, and 4. But their levels up to even to the maximum, up to level 6, is not based only in terms of the size or the sophistication of the building, but ideally it should be based on the service that they're able to provide. And this is based on the human personnel, the human resource that the human resource that they have. Like, for example, a level 4 need to have around 60 doctors, around 100 nurses, clinical officers. But you'll see that in most of these particular hospitals, mostly the public hospitals, there will be levels as level 3 or level 4, but the number of the personnel in them will be, I would say, 10% or 15% of the numbers that they need to have to offer the services. And at this point, somebody or a patient will go to get services, but they will not. They will have to be referred to higher levels or to referred to a nearby private facility. And in that regard, that will not be the right access to healthcare. And as Dr. Nicholas also explained, in this context of accessibility, we have the faith-based, we have the private sector, and also we have the public. But majority of the Kenyans will first of all go to the public sector to get services, whereby they would expect to have the disease that they have, get diagnosed, they get the drugs, and they get the services holistically. But many a times, they will end up, I think about 73% from the last statistic that was indicated, will end up going to visiting 3 or 4 facilities before they get the issue sorted. Basically, because of lack of the personnel that are required, or the hospitals are not well equipped to offer those particular services they need.
Okay.
So I think that, in a great extent, interferes with access to the healthcare.
Okay, Dr. Nyikal, what is the problem with the human resource in terms of getting people to work? Because we see, from the health committee perspective, why is it so difficult to just hire doctors? We can see us getting doctors from Cuba, and yet we have many doctors here. Why has it been a problem to just hire doctors, enough doctors?
For all human resource, you see, you even have had programs where the government is involved, where we are organizing for health workers to go and be employed elsewhere. And at the same time, you hear that in our own facilities, not here, you know that in our own facilities, there's shortage of nurses. Now, it is the management. It's the management of health human resource. Now, in this country, the health human resource is probably the most complex human resource you can have, not only in this country, across the world. If you look at health workers, you will start with, there are nurses there, you have clinical officers there, you have doctors there, you have pharmacists there, you have radiographers there, you have physiotherapists there. All these are people who have specific trainings. They are managed they were managed before in a unitary system. Now we devolved. Now when we devolved, this management structure, some of them actually have not devolved as should have. Now let's just talk about the recruitment of doctors. That I can talk about that, for example. Yeah. They are trained, and when they have trained, you have interns. Now interns are assumed to be still in training, but they are working. Now that is actually under national government. That when they complete, now they should be employed in the facilities. Now then they are now going to, and that is county governments. And there is no good, smooth transfer. I think they are working on it now. That is not happening. But if we just leave that, let's go into their organization. All these cadres I've talked about, they are well organized. They have regulatory bodies, the bodies that regulate them, their training, their registration, their conduct, and so on. These are actually national. They have unions, which are actually national, and they have associations. So each cadre has those three. Those are still national in structure. But we have not recognized that when they are dealing with them. So it gives us a lot of issues. Now, if you look at the Public Service Commission and the County Public Service Commission, again, you don't have a smooth transition. We have not worked out a smooth transition. If you have nurses and they are employed in one county, are they employed on exactly the same terms, or they are different terms? Are they transferable? Their training, when they are working, people still get trained when they are at work, particularly health workers. Is it the same across? Are they being managed in the same way? Are they transferable from one place to the other? Because these are now individual employers.
Yeah.
So those are issues that has given us problems. Okay. The other one is just actually managing them and recognizing their needs.
Yeah.
Look at what COVID showed, that health workers actually needed protection. They started dying, and they needed the protective gear. These were not available. They needed insurance. They also have health needs. So when they are sick, how are they treated? Yeah. Now, those things have not been looked at. So to a large extent, in my view, the problem is the management of the health human resource. Now, we have tried at the health committee, but remember, the health committee deals to a large extent with the national health at national level. Yeah. There is a health committee in the Senate. Where we are is in the National Assembly. Again, we have tried to actually sometimes come together to see how we can do this. There is the intergovernmental relations structures that again should be brought in, and I think they have tried. Okay. So to a large extent, it is management. There may be also issue of finances. Can we employ all of them? And what are the salaries that we gave them? You gave the issue of the Cuban doctors. Yeah. Actually, I think if you worked out what they were being paid, is definitely much higher than what the local doctors. We were ready to get that, but that I think was a political decision. And let me say it was kind of a knee-jerk reaction, that if the doctors here don't want to work, we can get some from elsewhere. It has been tried before. Yeah. It has never worked. Management of the human health resource is problem number one. Okay.
Davji, where does the problem lie from the union perspective in terms of human resources? What is the problem?
I think the first thing is that as long as we are looking at healthcare as an expenditure rather than investment, then we'll continue having a lot of problem in terms of human resource. When you look down a few years before devolution, the doctors used to graduate every year and be absorbed to different facilities in the country. But after 2016, then when the governors came in and became more aggressive in terms of wanting to employ, then the reduction in employment increased almost 100-fold. To this point, I'll say every year we have about 2015 up to about 2019, almost 600 doctors were being churned from different universities and being licensed. But then in 2019 and up to 2020, the numbers has increased to almost 1,000.
Yeah.
So when you look at overall in the country, in the last 5 years, you have about almost 4,000 doctors that have graduated. But if you look at the numbers that have gone into employment in the public or private sector, you realize about less than 20% of that number have been employed in both private and public sector. So there's a big number of doctors and a big number of nurses, a big number of clinical officers that have graduated and are not really employed to offer services. But then when you go to the hospitals, you realize that there's no services because there are no healthcare workers in those facilities. And one reason that why this happens is because the implementers of healthcare in the counties, that is, I would say the MCAs, the governors, even the senators, and even the MPs, and even the executives, the CSS and the CECs, they are not consumers of the same healthcare that they're giving to the people. So most of the times they will go for PR actions and try to show that there's an existence of an hospital when there's anybody with a lab coat and even if they're not doctors or they're not nurses or they're not clinical officers. So that's, I think, one of the failures that we've seen. So that's, I would say, a PR aspect, mostly in the counties. Number two, the county governments have been claiming or have been stating that the expenditure monthly expenditures for within the budgets goes up to 32% of their county budgets into the healthcare. And so with these, they have been unable to employ healthcare workers in many of the counties. And that's why one of the proposals that we had from the Afghan Nation, other People's Health Movement, with Amnesty, with all other CSOs, together with doctors' unions and other unions, was that if that is the case, then there's need to increase this budget to 50%, so that there could be services by employing healthcare workers to offer services in those facilities. Okay. And then the national one also should be increased to 15% as per their budget declaration of 2001. Yeah. Also to ensure that there's actually employment of the workers, because you will not say that you want to have services where we do not have those particular workers in the hospitals. Okay. So that's been the biggest challenge and the biggest complaint from the county government. But the ideal solution to the issue would be to have a centralized management of human resource, that is, having health service commission, okay, whereby the counties will just be asking this particular body that we need 50 doctors, we need 100 doctors, we need this number of clinical officers, we need this number of nurses, without considering the budgeting aspect of it, yeah, but with an aspect of ensuring that they're offering the services, okay, that they need to offer to the people. All right. I think that would be a better solution to the issue of human resource. All right. I have to take a quick break here on Daybreak. We're talking about the universal health coverage, and Dr. Umo Luga is now joining us. He's the Director of Health Services at NMS. Thank you for making time. When you come back, there's some questions that you're posing to him as well, and he has views on the issue of universal health coverage. We're talking about it in three ways: access, affordability, and standardization. Now, we've talked about access. We'll talk about affordability and standards in just a bit. Right? Keep your views coming at Trevor Mbija at Citizen TV Kenya. Use the hashtag Daybreak. We're coming back with some of your feedback shortly.
News breaks every day, anywhere and at any time. I can wait to watch it or read it, or I can be a part of making it. With my smartphone and the Citizen Digital app, I am a one-inch reporter. When a story I think people will find interesting breaks near me, I take pictures or video, upload it onto the app, and wait. It's not for nothing. If my piece is chosen, I enjoy a 1000 bob boost, and my story is published on the one-inch reporting segment on the Citizen Digital app. Share your story with one-inch reporting today. Don't just witness the news, be part of breaking it. Download the Citizen Digital app and share your story with one-inch reporting today. Citizen Digital.
Snack it with Fanta. Barbecue chicken sandwiches. In a bowl, combine the chicken and barbecue sauce. Divide the mixture evenly among the bottoms of the buns and sandwich with the tops. Serve with potato chips.
Snacking is a tasty treat. That's why snacking is colorful. Snack with Fanta.
Pewa kitu brother. Allah, kwani iko nini? Huwezi piga hustle na stress na bado ukule na stress. Piga sherehe mahali kuna kabriz kafiti. Hii stuff haitaki hasira bana. Jipe pole. Kwanza venye kumekuwa na mangori manze. Si bills, si stima, si nini. Tuchachishe bro. Lenga stress. Jipigishe shughuli. Jispoil. Kwani ni kesho. Piga sherehe.
Dial *811 *276# to get kwani ni kesho.
All right, thank you for staying with Daybreak. Keep your views coming at Trevor Mbija at Citizen TV Kenya. Use the hashtag Daybreak. We'll look at them in just a bit. And joining us now is Dr. Umo Luga, Director of Health Services at NMS. Dr. Luga, before you came in, we were just talking about the universal health coverage and wondering what would it really take to achieve it. And we're also comparing it to the pilot counties, Isiolo, Machakos, Kisumu, and Nyeri. What went wrong there and what can be fixed going forward?
Thank you, Trevor, and good morning to all the viewers. Good morning to my senior, Mheshimiwa Dr. Nyikal, and my successor, Davji.
Yes.
So I think a lot have been said about UHC for the last since 2017. You know, when the president once announced in December of 2017 about UHC, and then there was a one-year pilot program that involved the 4 counties. But you know, the framework of the pilot and the framework of what has been rolled out is different. As you noted, the framework was more of input-based in terms of commodities. And that worked in some ways, but also I think there are lessons that were drawn or that were learned from that pilot. For example, you know, the counties were chosen based on certain characteristics. But if you look at places like Kisumu, for example, where we were looking at an infectious disease burdened county, then you realize that there were some unsustainability, because people are coming to the facilities, and then the facilities, of course, were running out of commodities. It was more of an input-based framework. And the same, of course, with Nyeri and with Machako. So I think it is important to look at, it's not that it didn't work, it is the lessons. And therefore, I think there was a change in terms of the UHC policy that has just been rolled out for 2030. And now you see the shift is towards insurance, so that then you can try and engage from a perspective of outputs. But it's not purely an output-based. I think what you had talked about in terms of access, affordability, and standards, to be honest, I think there's been a lot of progress in terms of access. And access is in 2 parts. Access is in the actual facilities, and then there is access in the actual services. So you may have level 4, a level 5, a level 3, a level 2 hospital, but are the services available? So there are those 2 aspects to access. And just drawing from what has happened across the country, and specifically from where I speak here in Nairobi. For example, if you're looking at 3.1 million people who are residing in the informal settlements in Nairobi, we've greatly improved access. In fact, let me just tell you, in the year 2021, we saw 4 million patients. If you go back to the year 2020, 2019, 2018, 2017, Nairobi facilities have been seeing only 1 million patients. So you can see from 1 million to 4 million patients, there is actually more than 4 times the number of people. That already is a proof in terms of access, because these people, where were they going before? Now they are coming to the facilities. If you're just looking at maternity care, for example, we've seen an improvement in utilization of delivery services in public facilities from 32% to 54%. Just in 1 year again. And these figures are there in the Kenya Health Information System, or what was previously called the KHIDS, or District Health Information System. These figures are there for anyone to look at. So if you're looking at access, you can clearly demonstrate that something has happened. And I believe that some other counties may also talk about the same. If you're looking at affordability, that is exactly what the president was emphasizing in terms of now paying for the indigents, because many families go bankrupt seeking care. And the other flip side of it is that healthcare is not free, actually. Healthcare must be funded. It's either tax funded or patient funded. And then so you're just trying to lessen the burden of these families that go bankrupt trying to pay for care. So in terms of affordability, of course, there's the first 1 million people that the government has rolled out a program for 1 year to sort of pay for them. Like in Nairobi, we've paid for 66,000 families at a cost of 400 million, which these are people who have been ranked in a scale and found to be the poorest. Of course, we found that there were 326,000 people in Nairobi. But of course, because of budget limitations, you must start somewhere. So we started with the first 66,000. And you can see that is just 20% of the total number that we have to cover. But I think once a program has been rolled, there has to be concerted effort to coalesce all the resources. So, you know, there are a number of organizations, NGOs, there are CDFs, like the way our friends Washimiwas give, there are social funds that come from county governments. So all of this needs to be coalesced to now plug into that gap. So because the government has already done the first investment, so then now we need to rally, and including philanthropists, private sector, because a country has to develop wholesomely. I think the role of government is to do two things. One is to create the policy, and number two is to create the environment that enables people to also plug into that. And then the last thing that you talked about is the issue of standards. I think on that one there still has to be a lot of work to be done in terms of value-based healthcare. You have to look at the regulatory framework and the regulatory standards, not just for healthcare workers, but also for standards for infrastructure, standards for services itself, because I think we still have a huge gap as far as standards for practice is concerned, you know. So how a neurosurgeon, even if you were to provide the neurosurgeon, provide them with all the equipment, provide them, you still have a huge gap as far as how a neurosurgeon would do, would practice in Kisumu versus how they would practice in Nairobi. So even that in itself, so it's not just about the number of healthcare workers, it's not just about the norms and the standards for HRH. But let me mention something about the issue about the healthcare workers, because I think that is, of course, where I have come from before, and that is still I think there's a bit of pain in terms of the weak link with the UHC. I think there has been attempts to sort of solve this problem. And for me, from where I come from, with the political will that has been demonstrated with the UHC role, I think it is also our work as healthcare workers to sort of look at what is it that works for us. Of course, there is what the Constitution says, then there is in terms of devolution, but then there is also what is practical as far as services are concerned. And I think it is important. Right now there is, of course, a healthcare workers conference that is still going on. I believe my friend Davji is there, but they are just looking at the curriculum. But there is need for us healthcare workers to draw back and to really look at what would be in the best interest of the patients, and then reorganize there. And it is true that there have been some delays as far as flow of funds are concerned from the national government to county governments. And those delays affect salaries, those delays affect the manner in which counties can support healthcare workers. In Nairobi, for example, we increased the number of healthcare workers by 33%. We had only 3,300 healthcare workers. Now we have 5,100. And we employed more than 2,000 healthcare workers. But that does something that is also important to discuss, the wage bill, because our wage bill jumped from 35% to 58% of the budget. Now, in terms of sustainability of the services, this is something that healthcare workers cannot ignore, because you must create the space, and they must be part and parcel of that. So if we employ 200 doctors, there has to be commensurate output in terms of the services. Of course, for us, we can talk about the output in terms of the number of patients have increased from 1 million to 4 million. But in terms of the quality of the care, that there should also be an output there. In terms of the revenue, there should also be an output, because I mentioned that healthcare is not free. It's funded. So it's funded from the tax, or it's funded from the patient. So if the patient, we've already bought for them NHIF because they cannot afford, this money must come back to the facilities, because that's the only way that you're making it sustainable. And for us, we looked at those four aspects. We looked at the issue of access in terms of the real facility, the issue of access in terms of equipment, the issue of access in terms of healthcare workers, and then we are looking at now the policy framework that is going to make the services sustainable.
Okay.
And that is important. So I think in a nutshell, I'll summarize that it is possible for us to achieve UHC, but we must all be committed, and we must all not just be committed in terms of the words, but our actions must speak. And that action is not just a political action, it's not just a management action from Ministry of Health, it's not just the county government. I think the healthcare workers, we, and I am in this group, we must also go back to the drawing board. And that's partly why when I was requested to join Nairobi Metropolitan Services from the union, I did so, because then you must also be part and parcel of making the change that you speak about.
All right, Davji, and now you can hear your predecessor. Before he used to speak your language, now he has a different version of these events, and he has the numbers that go with it. Do you agree with most of the things that Uma Oluga is talking about?
Thank you, Trevor. I actually agree with some of the things that he's talking about, and especially in terms of the aspect of the human resource. I think based on what he has done in NMS, it was a clear show that there was a gap in terms of the management. And that's why you realize that he was there for a year, and with that period, there was an increase, first of all, in the number of the staff, that is the number of human healthcare workers that will actually ensure that there's service provision. But to realize that is different in all the other 47 counties. And in our tabulation, in terms of the workers that have been employed in the last 2 years, it was only, I think, NMS that had the highest number of workers employed. So basically, that will make is making NMS things to work. But if you look at it, it's not working in the different sector, in the different counties or different parts of the country. So that's a reality. The other thing is on the financing. It is clear that if the counties and even the government does not prioritize healthcare by putting more funds to it and investing deeper into it, we won't be able to have the health services that we need. So that is also something that we need to check at. And ideally, from what you have said, NMS is directly from the office of the president, which then makes things to be able to operate. So if we then do not have the 47 county governments and make healthcare to be a centralized service provision, then whatever's happening in NMS is possible to be achieved elsewhere.
Okay.
Trevor?
Yes. Dr. Nikal? The Oluga says now it's time for the doctors to go back to the drawing board. Is that where it begins? And Datela is saying that now the difference is he has support from the national government.
You know, all this, they are all my... let me say they took over from me because when I was chair of KMA, I was doing both the union work.
We are only students.
And the welfare work.
They're all your students.
But we were on affordability, but let me go back on the issue of the health workers themselves.
Yes.
It is true, as health workers, we must also take the responsibility. Whatever people may say, the health workers are actually the leaders in the service provision. Because whatever else you put in place, if they don't work or if they don't manage it, people sometimes think they don't have to manage it, somebody else can, but that doesn't work. So we must also come in and give the commitment that is required. This actually becomes a problem at higher levels where it is possible for the doctors, for example, to be both in government and in private practice. And then the distribution of the time, where do you put more time? That becomes a problem. We must be committed that for what we are paid, we provide that. The other one is just the human element, that when you are looking after sick people, as a professional, you actually have more responsibilities than all other people behind you. That is why if there's a failure at the hospital level or at the bed level where the patient is, they see the health worker. They don't see, even for the cost of care, they see the health worker. They don't see all the other people that are behind the health industry that eventually terminates in the health worker and the patient being together. So we have that responsibility. And it's not that Tuluga is now on this side. I faced the same problem when I became DMS from being a chair of Kenya Medical Association. But we agreed with my colleagues. We work for the welfare of health workers because they provide an important service to people. In fact, their value is in what our value as health workers is in how we take care of the people. We lose that, we lose the respect that people give us and even the expectation of the society. So he's right on that. But coming back to affordability, you see, it is the cost of care. Health care is not, it cannot be free. It is just who is paying for it.
That's true.
Either the patient pays out of pocket, and that is what impoverishes everybody. Trevor, there is nobody who can afford health care. Even the most well-paid people, even the richest people, if they have serious illness, if they didn't have insurance, they would literally be wiped out. So either the patient pays, or the government pays, or you go through insurance. Those are three. In all cases, there is the issue of the cost of care. Affordability seems to imply whether you can access it with the resources you have. But the bigger thing is the cost of care. And I think that is what we must look at in the country. In the public facilities, the cost of care is not seen so much as you see it in the private sector, but it's basically the same thing. So what are the costs of care? What are the drivers of the cost of care? Let's take the private sector. It gives us a better example. We can extrapolate it to the government. First of all, it is the cost of the health workers. If they are in private service, it is the consultations, the cost of the services they give, like the surgeries and so on, relating to the person who is doing it. In the public sector, it actually comes out as a salary that is paid to that person. So it is still a cost. But in the private sector, there's a consultation you pay, there is a service you pay for, procedures you pay for. So those procedures are a big cost of care. The other cost of care, if you are admitted, is actually the cost of the hospital, which would come out as what you pay as a hospital, the hospital bill you pay to the hospital. The other one are the inputs. And what are the inputs? The drugs come out first, but there are a lot of other inputs. So as a country, we need to look at the cost of this, and it will also come to standardization. For surgery, what should be the cost of surgery? What do you pay? And it is possible to sit down with the doctors and the people who are paying for health services, the consumers, and agree that for a cesarean section, this is what we should pay. Across board. Across board. And we'll work it out from its cost, which affects even the public facilities. And for this surgery, it is this. Then you will say, if you sleep in a hospital, even before you are treated, a hospital is first of all a hotel. So if you sleep there, what is the cost of that? Then there will be the nursing that you will get. What is the cost of that? 3, what then is the cost of the inputs, the drugs in particular, and this? We can sit down and actually say, from the market where we buy all these things, because we don't get them, this is the cost. And the doctors can say, we will charge this much and agree on it. And we have an arrangement, an institution. It can be by law, like in other countries. Every year, that is reviewed. Then what the hospitals charge, the hospital can sit down with the government, with the consumers, and say, for this type of hospital, what is the bed charge? The bed charge, unfortunately, will have some elements which are not health related. You may want to go to a place where you want a TV in your room. That we can take out. Then drugs, we can say, because drugs is an area where we can make a huge cost saving. Reduction. Because when we talk of generics, people think generics as inferior drugs. They are not. It is just that the original molecule was invented or formulated by somebody, and therefore they tend to be very expensive. People copy them, and some are copied perfectly. I know a drug that I've used before,
Yeah.
that the regional is about 75 to 100 shillings a tablet. And there is a generic that is costing 5 to 10.
shillings.
And
Yeah.
I can tell you it works.
Yeah.
So we can then have a formulary.
Yeah.
What do we use in our facilities as a country?
Yeah.
And we can agree. And we can have a body that, reviews that every year.
Okay.
So when you do that, you reduce the cost of care.
Yeah.
And that is required
Yeah.
even if you are on insurance, even if people are paying individually, even if the government is paying.
Yeah.
So that is another area we need to look at to address the problem of affordability.
All right. And Dr. Luga, what would it take to achieve what Dr. Nyikal said? Because those are brilliant ideas.
I think Dr. Nyikal and I, we belong somewhere else where we have proposed, you see for things that are very important in terms of economic drivers, for example, fuel or energy, there is an institution called EPRA, Energy Petrol Regulatory Authority, that actually Kenyans usually look forward to the prices that they gazette. Of course, we can debate about that. Yeah. And Dr. Nyikal and I think maybe he's shy enough to say it now, but I think we have proposed quite a bit of changes, including how to look at cost of healthcare, and to actually have a body. We have, and we hope that Kenyans will be kind enough to take some of our proposals when they come in August of 2022, because this is the way to sort it out, so that you do not have patients fighting with private hospitals, you do not have doctors fighting with private hospitals in fees that they are owed, you do not have public hospitals that do not have drugs because they are not sustainable. As I mentioned to you, for example, when we increased our health workforce, remember the wage bill went to 58%. And that also eats in the budget that I have for recurrent expenditure. And as I mentioned to you, the number of patients have increased. So the number of gloves, for example, that you are using for 1 million patients, you still have the same amount of budget
for 4 million.
For 4 million patients. So you see, and of course it is very easy if you are not in the room to talk about, the budget should increase. But as you know, what Dr. Nyikal and myself go through on a daily basis, like right now when we face either budget committees in Parliament or when we face other planners, they ask you only one question: does it mean that the budget for water should go down so that we increase your budget for health? And I think that is why, for me, I am inviting very humbly the colleagues in healthcare and the healthcare workers, because I think we, having had this knowledge, we need to go back to the drawing board to look at just one thing: sustainability. And sustainability is sustainability of the financing and sustainability of the services, so that they are consistent and they are quality. And one of the things that Dr. Nyikal has mentioned is very important, where we are proposing a cost tribunal, of course, or you can talk about an authority, which myself and him, we've discussed at length. We've looked at the structures, we've looked at the problems that are possible, so that we can have a way to guarantee Kenyans that they will not always be fighting when they are suffering the most. But more importantly, at the hospital level or at the healthcare systems level, two things. One is to look at other cost or basically finance inputs other than taxes. And without going very far, we have, of course, Dr. Nyikal has mentioned the private insurers, which is still patients paying because you have to pay for your insurance. But then there is also the NHIF, which for a long time has been a bit skewed towards the private sector. For example, 84% of all payments coming from NHIF go to the private sector. In Nairobi alone, NHIF pays around 14 billion. And out of this 14 billion, 13 billion goes to the private sector. And you can see the imbalance. And so if you're also looking at the metrics, for me, and I want to be very honest here, you look at the actual numbers, look at the actual numbers of people treated in the private sector versus the actual numbers of people in the public sector. So it's not necessarily a comparison so that you say that this is bad and this is good and then you want to lock out one group versus the other. No. But it is important to balance in terms of healthcare financing. So, and that is why for us in Nairobi, and I've seen our colleagues in Machakos have also followed suit, out of all the 118 hospitals that we have signed contracts with NHIF. And the reason why this is important is because I can sit from where I am as a director of health or as a manager, but if the healthcare workers do not buy this, then that work is zero. And that's why I'm trying to say that we must invite our colleagues from a sustainability perspective, that if I work as a doctor and I can claim that 250 shillings from NHIF because the doctor is already employed and is already paid a salary, then that money comes back to the hospital. It also helps the patient. It helps the patients in two ways. One, it helps them to make sure that the commodities that they so need can be replenished at the hospital level without asking the same Kenyans to pay more tax. Because then the other way is for us to say that the 1 billion that we have for commodities is not enough. So we want Parliament to give us more money. And when Parliament gives us more money, it means that someone has to pay for it. There has to be a tax somewhere. So I think the healthcare workers must also go back to the drawing board and say, how can I also be part and parcel of this? The second thing that it helps us do is that it helps us improve the quality and the consistency of service. Because then today you come, you get a surgery, and then tomorrow you come, you don't get a surgery because maybe linen is not there, maybe something has not been paid, maybe a theater has not been developed. So I think we need to have a very serious internal discussion, especially with the political will that is there. And in addition to what Dr. Nyikal and myself are discussing elsewhere, so that we can progressively see to it that the Kenyan, the you and I, my brothers, my sisters, when we go to a hospital, we can actually get the care that we need without having to worry on whether we are going to sell the goat or whether we're going to sell the land or whether you're going to get stuck in a hospital. In fact, right now we have even doctors themselves, and I've been in this position, that get stuck in hospitals, including in India. We have to fundraise for them. It's very embarrassing. So there is no one in this country who can afford healthcare. So it is very important that we are discussing it from a solution perspective and looking at what am I going to do as an individual, as part and parcel of this process, so that we are not just saying that, oh, you know, that is for them. You know, that policy, that UHC policy is for them. It's also for you. So you have to look at what is your responsibility as a Kenyan and what's your responsibility as a healthcare worker.
Okay, there's a lot of feedback coming through, and Davji, I'll come to you in just a bit. Let's bring up some of the feedback and see what your questions are before we take closing remarks on this conversation on whether we can actually achieve universal health coverage. And there are two main things that are happening. Dr. Duale Jr. says, Davji and Oluga, the contract of UHC employees is coming to an end soon, early 2023. What plans do you have for them after end of program, since they will be 10,000 UHC employees unemployed? Or Dr. Luga, quick reaction to that.
I think this is part of actually what, I don't know whether my colleagues mentioned in terms of, in total there are even 15,000, the number of people that were employed as part of UHC to plug in the gap. And I think the Public Service Commission has already given some directions as far as the contract workers are concerned. I believe it is now the responsibility of my friend Davji to engage with Public Service Commission and the Ministry of Health to find a way to ensure continuity. Of course, you know what I usually tell the workers, the hospital is going nowhere. The demand is going nowhere. The services that we give is going nowhere. So I think we should also be calm enough in terms of the engagement, because we are assured that if we are progressively moving forward to achieve UHC, your services will definitely be needed.
Okay. Davji, is there any progress in that front?
I think there's a progress from the perspective of the Public Service Commission. But then I'm partly from also the ministry regarding the UHC doctors, UHC workers generally, because there was a framework to put them on a permanent and pensionable terms. But then it did not really include all of them. That's why I think there's partly those who have been taken part, but those who are on special programs, I think those are the ones who have been left out. Basically, I think and I think that's particular thing that the person who treated that was asking for. That those I think are still in the framework and are still in the process of pushing for or asking for them to be absorbed up.
Okay.
I wanted to put something on affordability based on what my brother Oluga and my colleague Dr. Nikala said. I think the picture they bring about is on the policies that need to be made to ensure that there is actual cost effectiveness in service provision and there's service provision in the facilities. But the policies and the frameworks that they're putting in place are they're really good. But Trevor, if you go down county governments and if you go down to the facilities out in Nairobi, then the story would be very different. These policies and frameworks that are made from the Ministry of Health, that are made from the Parliament, that are really good, that will help every Kenyans to get access to healthcare, to even afford healthcare, are not implemented. And that's why we keep on saying that if we don't have Health Service Commission, which will ensure that these good policies, these good frameworks are actually implemented and ensure that the service provision in overall all the counties. But this can only happen when you do not have these guarded by governance in different places. As Oluga said, that there's about 58% of the budget that NMS has taken to ensure that they have an extra number of healthcare workers. Most counties, if not 80% of them, have their budgets at 30%. And that will tell you that they're all operating at almost 30% of their level. Yeah. And that is clearly demonstrated by what Dr. Luga is saying. So in most of those cases, the affordability of healthcare will not be realized. And why am I saying this? Because most Kenyans will go to the public hospitals, which in many instances do not have the doctors. They don't have the healthcare workers. They do not have the ability to diagnose or to have the diagnosis checks of the patients. They do not have the drugs. So most will end up in the private sector, who at the end of the day, we will all be bargaining and start talking about how do we fundraise for the service provision. So ideally, if every county will be doing what's happening in NMS by increasing the budgeting of healthcare, as I told you earlier, we have this Afia Nation movement, that's the People's Health, whereby we are putting up and demanding that every county to at least put 50% of their budgets into the healthcare. Yeah. So with that, you can realize that then there will be more accessibility, there will be more affordability. But if that is not the case, then you realize that many will be in the private, will go to the private hospitals. As you all know, when we talk of public, when we talk of private, we talk of even faith-based, the ideal situation is that the person who is in a private sector uses more money, uses more funds to run the facility. And therefore the health there will definitely be much more expensive compared to the faith-based and even the public, because there's more of a support from the government on those sectors. Okay. So that's one thing that we have to look at. And the part that I want to really bring out is an example of a doctor who has served for over almost 20 years in Nairobi University. He's a psychiatrist, and this doctor got sick and was admitted in Nairobi Hospital, despite working at the University of Nairobi. The doctor was detained when he was alive. And this is a matter that we brought to Health Committee, the matter that we took to the Ministry of Health, it's a matter that we canvassed everywhere. The same doctor died, and the body has been detained at Nairobi Hospital for now over 3 weeks because of the bill that has not been paid. And this happens a lot. The other time we have also a doctor from Bungoma. After being saved, actually, he was very sick, had COVID, went to Moi Teaching and Referral Hospital. You realize that the time the bills were calculated were over 600,000. And when, as much as counties pay enhanced comprehensive cover into NHIF, the cover did not pay for this particular doctor. So the people have different doctors and teams had to do fundraising to collect and pay for this particular doctor. Yeah. So if doctors themselves are not able to afford these particular services, how much more do you think the Kenyans will not be able to afford them? Okay. So, and that is the reality of the ground. Yeah.
We're running out of time here. Dr. Nikala, I'd like to take closing remarks from you on this. Can we really achieve universal health coverage at the end of it all?
We can. Yeah. If the country is committed, we can. And Dr. Luga was implying there's something we're doing, he was making secret. There's really nothing secret. In the Azimio manifesto, we have made an input on how exactly it can be done, looking at the cost of care, looking at the standards, putting in legal structures that will make those things happen, looking at financing, the pooling of resources. And we have decided that social health insurance through NHIF is the way to go. The hindrance has been who pays for the indigent. But there is enough money in this country to do the indigent. If you hear like we are saying we can pay 6,000 to people, those are the indigents, then we only need out of that 500 shillings to pay their insurance every month. And then it can be done. It has been done. What we need is political commitment, clear policy arising from a manifesto that is in place. But I want to say something about the UHC doctors. There is the problem we have is transition. When the health workers were working as there's nothing like UHC doctors. They were working as doctors treating people. Those people are still there. What was needed is when we are moving from the pilot to now the full thing, is to make a transition for those who are in the pilot, how they continue to. In an ideal situation, they shouldn't even know. And there's one thing I want to say, really, there is a trend to employ health workers, particularly in the counties, on contract terms. I think it is something we should discourage as a country, because people on contract terms are not committed. They are always worried. They are thinking of their professional development and career growth, and therefore they cannot work with commitment. We must actually make health workers feel safe, pursue their careers as they serve people. But my closing remark is this. Universal health coverage is possible. The money is there within the system. The loss is actually two ways. One, in managing is two, fraud, that people get money for which they have not provided services, and people go for services that they are not entitled to. It can be done.
All right. Trevor, I think for us in Nairobi, for us, actions speak louder than words. I think people are aware of where I come from, and even my bosses now. For us, we work, and we've done it. We've increased the number of hospitals, we've increased the number of equipment, we've increased the number of healthcare workers, we've increased the number of patients that we are seeing. The indicators are there for themselves in terms of even skilled birth attendance, in terms of maternal mortality. We are only still grappling with a few issues of perinatal mortality, which has been a big problem in Nairobi in terms of children. And the numbers are going down, but that is something we are still grappling with. But in all the other indicators, we have more than improved quality by more than 50%, except for the perinatal issues. So we have done it, and it can be demonstrated very clearly. And what we are now looking at is sustainability. And this sustainability is as far as policy is concerned, but there also has to be a culture change among everyone in the health system. And when I say everyone in the health system, it is from the MCA to the MP to the patient to the healthcare worker, in terms of a culture change, that this is possible. We must first make the decision this is possible. We in Nairobi have done it. We are looking at now sustainability. We have signed the contracts. We are going to engage with our healthcare workers also to have this positive culture of being present at work, treating patients with dignity and being humane to all of them, and making sure that we are also pulling other resources from NHIF. We are just engaging with the teachers, medical administrators also, so that people can utilize these services, so that the services themselves attract enough revenue that can make them consistent, that can also plug in the gaps for the commodities that have been a big issue, that can plug in the gap, including for extra healthcare workers. For example, we do not have enough anesthesiologists. We have improved more than, we only had 4 theaters in Nairobi. We've done more than 7 more theaters. So you can see we need more anesthesiologists and anesthetists. So it is possible. UHC will be achieved, and hopefully, of course, with the discussions we're also having with Dr. Nyikal, it will be something of the past.
Okay. All right.
We will no longer have this discussion. If Kenyans allow us to go that direction, we will no longer have this discussion.
I see how careful you are with that statement. Let's see what you're saying as we wind up on this conversation. Crispinas Adam says the biggest obstacle to the UHC is the inefficiency of many county governments in management of healthcare. There is need to help build capacity and streamline the services in non-performing counties, okay? Dreamara says universal health coverage will help a lot. Many citizens have been suffering and struggling to pay for health services. With the UHC coming in, the health sector in the country will improve at a larger percentage, okay? Keronza says the government has poorly managed healthcare workers. Imagine some have never been employed since they graduated from 2014. 8 years with no jobs, okay? Inya Kweba says UHC is a good thing and it can be easily achieved. The main enemies of UHC are lack of goodwill from those in power and corruption in the health insurance, that's NHIF, and this will highly affect both financial, physical, and professional accessibility. Wycliffe says UHC would be a dream unless the national government takes over health services. Most of the government facilities do not have basic life-saving drugs like paracetamol and non-pharmaceuticals like gloves and patients have to buy. Staff are never paid, no amenities like electricity. Okay. Dr. Michael says the human resource also need to be well trained. Currently, we have a lot of misinformed services being rendered at our facilities. Okay. Ombati Doctor says in order for UHC to succeed, we need a Universal Health Act that governs healthcare from financing to human resources, etc. Otherwise, governors' selfish interests will water down the noble and progressive UHC idea. Dixon Oluwach says a major problem in public hospitals is lethargic nature of operation and I don't care attitude. They are always in a group over stories, ever on phone. Sometimes you can wait for 2 hours for the doctor to arrive. I think there should be a law compelling all government employees to use government facilities unless they're not available. That issue of doctors being away and taking too long to serve people, Luga, how can that be addressed? Have you addressed it in the NMS?
Yeah, we are addressing it. Of course, that's part of the culture change. I think sometimes I cloth my words, but I think that's part of the culture change that I spoke about.
Yeah.
We are addressing it in several platforms. Of course, the first and foremost is that if you are given a job to do, just do it. I think it is improper to want other people to follow you to do their job. Personally, I've never been followed to do my job. You know, you just do your job. And if you think that you have another job elsewhere that is more important, go do that other job and leave space for the many unemployed healthcare workers. But of course, from a management perspective also, we are looking at two things. One, of course, is support. Because support is very important, and that's the support that I was talking about. You know, part of also the issues that healthcare workers have had is lack of support within the facility. So that lack of support has also brought in lethargy, has also brought in the environment when it is not conducive. So, you know, the same things that we've been talking about, we've been trying to enable the environment so that they work, they have the tools, they have the commodities, they have, for example, even the launches, the call rooms. You know, that's very important as far as healthcare workers are concerned. But also the other bit of it is accountability. And on the accountability side, we have partnered with University of Nairobi and through support of USAID and others. And what we are doing for us is to have digital mechanisms of accounting for both time and workload. And this is, we also started with it as a pilot, especially in the new facilities, and it's being rolled out to all the other facilities so that if you're meant to be in a facility for 8 hours, you will be there for 8 hours. Of course, I have mentioned the first bit, which is usually the big bone of contention, that what am I here doing for 8 hours? So, of course, we're giving you the support, but you're also supposed to be there. And then the last bit about it, which after the availability, you know, we used to be told by one of our professors that an available doctor is better than a good doctor who is not available. You know, so once we give you the support, you are available. The other bit about it is now what we call work design, so that we make sure that at that hospital level you have enough capacity, and capacity is both in the skills and capacity is also in the way that the other nurses or health workers are integrated, the way we design the work to make it work. I told you in Nairobi, for us, we are action oriented, so we do more than we say.
Trevor, I see you are keen close, unless they're going to jail you if you take more minutes.
Yes, they are going to jail me.
Two things have come out.
Yes.
That government employees should be forced to use government hospitals.
Yes.
It tells you historically where we have gone.
Yeah.
I practiced when government hospitals were better than private hospitals.
Yeah, it's possible.
At the early time of my practice, we transferred patients from Aga Khan to Kenyatta. I admitted ministers in Kenyatta. It is a matter of improving the facilities that we can. True, there was one of inefficiency at county and need for support for counties. I think there's been an adversarial relationship with the county government and the national government. I think that is not useful. It should be supportive relationship, cooperation and supportive. They are trying. Obviously, counties are new. They can't have the capacity that the national government has. So the national government should look at supporting them, putting standards with them, putting policies with them, and supporting them to implement those. And not fighting.
All right, gentlemen, I really have to leave it there because we ran out of time, but I'm sure we'll have this conversation again. Dr. Umo Luga, Director, Health and Services, NMS, Dr. Davji Atela, CEO and SecGen, KMPDU, and Dr. James Nyikal, Member of Health Committee and also Member of Parliament for SEME. Asante sana for making time. Let's leave it there for now. We're taking a quick break. When you come back, Willis Bazuraburu is on the decks. It's still about health, but the topic of discussion will be on how to cope with gastritis and hyperacidity. All right, see you in just a bit.